ethics committee, which every study has to do. Nevertheless, I thought that the patients on 80 milligrams might have been at unnecessary risk. And then they defined compliance as equal to or more than the scheduled tablets being used up, but in the end, it went down to 69%. So it may not make any difference, but you begin to wonder. But then, if those that dropped out, dropped out because of the muscle pain, maybe that would match the number that dropped out just because. So maybe on average it might have been okay. So now the FDA, about a half a year later after this came out in June of 2011, while the study came out in November 2010, they were saying, okay, go for 20 milligrams a day, but they did say none of these drugs, the antifungal azoles, the erythromycin group, and a few others, and then the grapefruit juice, I finally found the quantity. You know, you put on that sticker, do not have any grapefruit juice, and when I was in retail, one patient begged, can I have just 1 cup? And I found one study that said 250 milliliters, so that's a cup. So the other pharmacist, I didn't want to stick my neck out too much, and the other pharmacist, yeah, just once, 1 cup. Okay, go for it. And so most studies say a liter, that's 4 cups a day. And then the HIV drugs, and then the other 3, nifazodone, danazone, cyclosporine. Those are just absolute contraindications. Then you can decrease the dose to 10 milligrams instead of 80 or 40. So this patient was on 40 milligrams a day. So when she was getting the verapamil, that's why I stuck it in there. So she should have been put on 10 milligrams instead of being on the 40 milligrams. And then maximum 20 milligrams a day for the amiodarone, amlodipine, ranolazone, and lometabide. So these are the ceilings for the simvastatin doses of these drugs. And then there's the prevention. So there's the liver function test, the renal tests, and the genotype testing. And then in the literature, they did mention that other variants exist, and they also said that even without the variant, that they could still have the myopathy, just having the gene alone. And then when you want to go to alternatives, you'd have to have the simvastatin dose to transfer from the simvastatin to the other drug. So from simvastatin to atorvastatin, you go half. So instead of 80 milligrams or to 20 milligrams of simvastatin, you'd go down to 40 to 10 milligrams of the atorvastatin. And for rosuvastatin, just 1/8. So you just go down to 10 or 5 milligrams instead of the simvastatin 80 or 40. So there is a way to manage all this. And don't forget to take your anti-cholesterol pill. So the risk factors, the 70-year-old lady with diabetes, which this lady had. So they say other major disease states, and a 3A4 inhibitor like verapamil is one. She had a normal renal function, and the authors decided to use, instead of atorvastatin, they said because it was lipophilic, they decided to go all the way to as much hydrophilic as they could, and went for the fluvastatin. So in summary, why did the FDA limit the dose of 80 milligrams? They found that the therapeutic dose was still at 20, and that the lower risk of myopathy. So the balance, they kind of balanced it out at 20 milligrams. again, who's most at risk? The 65 or over lady who has a low body mass index. And maybe that's why they said that the Asians were more likely, they're smaller in stature and they may have less muscle mass. And then renal impairment would add to it, and uncontrolled hypothyroidism, Asian descent, and then the genotype. So we would like to apply the lab results to change the therapy, and there is the creatine kinase levels so it's the stages. So I left out just the plain myalgia, and I went to the incipient myopathy, going downhill, down, down. So that's kind of a reference, 3 to 10, 10, 40, times the upper limit of normal. And then there are other tests, liver tests, that one could take, the ALT, and you would see doubling of the creatinine. Plasma creatinine would indicate rhabdomyolysis. And then, again, the genotype. So when does the patient need some medical care? The early symptoms you might see, muscle pain, the tenderness, the weakness, nighttime cramps, tendon pain, dark or red-colored urine, and unexplained fatigue. So what would you do as an outpatient pharmacist? I used to ask every single patient on any statin, what symptoms do they have of muscle pain? First, do they have any muscle pain? What are their symptoms? And then you would triage the patient to their physician to, if they answered positive, they would make the patient I would make the patient aware that they could go to their doctor and get a different statin, and that it's genetic, and they should and they could get tested at the doctor's office. And then alert the doctor to the same, as well as any drug interactions that you might notice that would be causing the myopathy, increased levels due to the myopathy. As an inpatient, you could, as soon as you see somebody on a statin, you could ask the doctor to order a pre-levels or time 0 for them in the hospital of the serum creatine kinase and a genotype test, and to get a lower risk statin and address any drug interactions. And then you could be monitoring the lab values. You have the advantage over a retail pharmacist. You can look at creatine kinase levels, pre-medication and ongoing. How many multiples of the value is it of the upper limit of normal? And alert the physician when it enters the incipient stage of 3 to 10 times the upper limit of normal. And monitoring the genotype, and you could ask the doctor to change the drug altogether. And I'd like to thank you very much for your participation. And have you any questions?
How much does it currently cost for that genetic testing, or do you have any idea?
I can find that out for you and email it to you.
Okay.
I'm not sure at this point.
Is it readily available, or are they doing it? I've just never seen it, so I'm just curious.
There are many articles that came out, even 2010, 11, 12, 13, so it's out there in the literature, so it's not like it's so new for everybody. So
just curious if it's cost benefit,
right,
in our medical system these days,
right,
how we are, and if they're just randomly changing statins if they suspect, rather than, it also makes you kind of curious why they're even using Simvastatin at all anymore with
right,
some of the better, other than price.
Right, well, the other thing that the FDA said is, we're not saying that everybody should get off of 80 milligrams. If somebody is doing fine and well on 80 milligrams, not getting any muscle issues, well, of course, then they don't have the gene.
Right.
And then you could continue that. But to start people on 20. So maybe they'll start doing it just empirically. Let's take a stab in the dark. We'll start you at 20, and if that does the job, fine. If not, I guess we'll have to move up, and then
Right.
they'll just back off if the person has myopathy. That's another way around it,
Mhm.
but it sure would be interesting. And then the other thing is that they did not, in this study, do blood levels of the simvastatin, because that could be a surrogate marker. They didn't do blood levels of the simvastatin in those who had the gene. So that could be another study that somebody could do.
Why did you choose this topic?
Well, I thought, you learn about the drugs, you learn that myalgia and rhabdomyolysis, which is less frequent than just the plain myopathy. And I kept on asking patients, do you have the muscle pain? Do you have the muscle pain? On and on and on. And not that many said that they did. And I thought it was much more common. You read the side effects, it doesn't really necessarily say this percentage of people taking the drug. And it turns out it's about 15%. The prevalence in this study was about 15% of their study participants had the gene. So that probably explains why I didn't get that many yeses. I got a lot of no's, no problem. Okay, thank you very much.
Thank you.
You're